So thank you to everyone for joining us this morning. Again, this is our inaugural journal club for the Veterinary Endoscopy Society. Incredibly honored, incredibly privileged to have Dr. Lynetta Freeman here for the inaugural event. Again, when Dr. Singh and I were deciding as to who we thought would be a good first representative for a journal club, both independently thought of Dr. Freeman and couldn't be more excited for her to kickstart us on the journal club. Dr. Lynetta Freeman is a professor emeritus of small animal surgery and biomedical engineering at Purdue University. She brings extensive experience in teaching open and minimally invasive surgery, developing surgical procedures and devices, and in conducting basic research in wound healing. During her tenure at Purdue, Lynn served as a clinical soft tissue surgeon, taught the general surgery course to the third-year students, and led the Priority for Paws program to serve shelter animals with a mobile surgery service for fourth-year students. She's performed basic research in wound healing and NOTES, or natural orifice transluminal endoscopic surgery. She's a diplomat of the ACVS American College of Veterinary Surgeons and was recognized as a founding fellow in minimally invasive surgery. Throughout the presentation today, Dr. Lynetta Freeman is going to be discussing surgical smoke. As she's speaking, there is an ability for anyone that is in attendance to chat. And so if you have any questions throughout her presentation, please feel free to type any questions, any comments into the chat area. And I will be moderating throughout to be able to answer any questions or direct the questions to Dr. Freeman. And similarly, it sounds like she may be asking us some questions throughout the presentation, so please feel free to answer either through the Q&A or through the chat box that's available. So with that, I will pass it on to you, Dr. Freeman.
Okay, thank you very much, Chris. It's a pleasure to be here today and to just bring a topic for discussion that's been on my mind for a really long time. I started becoming interested in surgical smoke way back in the 90s when we started using lasers. And we actually bought a smoke evacuator for a laser that we had at the time. And then it seemed like smoke evacuators kind of fell out of favor. But recently, I've just become aware of this problem and started thinking about it for the impact for us and our future generations. And so I just wanted to create some awareness and bring attention to this topic, and hopefully we'll be able to generate some research in this area in veterinary medicine. For this presentation, I'd like to acknowledge Dr. Kay Ball. She is a perioperative nurse, and she's past president of the AORN, and she's written numerous articles on surgical smoke, and much of this presentation I actually have borrowed from a presentation that she gave not too long ago. So with that, we'll kick it off, and I'm going to give a little bit of background on surgical smoke, and then we'll talk about the article. So our goals for today are to really discuss the potential hazards associated with exposure to smoke, and something that I really wasn't aware of so much until I started doing the reading, bioaerosolations. That is the aerosol that's created when we use drills and saws and things like that. And then at the conclusion, we'll review the article comparing smoke evacuation practices for open and laparoscopic procedures. I picked this article because it's a fairly good review article about the topic, and then there's a little bit of comparison between open and laparoscopic procedures. So there are many types of devices that emit surgical smoke and bioaerosol. Electrosurgical units, of course, ultrasonic devices, even the advanced bipolar devices create some smoke. Argon beam coagulators do also, and then lasers we know about, and saws and drills. And it seems from reviewing the literature that there was a high attention paid to lasers and surgical smoke, but not so much to the electrosurgery units or the other devices. And so for that purpose, we'll be talking about that today. And I'm sorry, but they just started mowing the lawn. It'll take about 5 minutes and hopefully they'll be done. What is surgical smoke? Well, what causes it? Well, what happens is when we apply an energy source to tissue, the energy heats the cells up to a point of boiling, and then it vaporizes. And so surgical smoke is composed mostly of water vapor, steam, 95%, and then the rest is other matter such as organic and inorganic compounds, particulate matter, and even microorganisms. And I'll go into a little bit more detail on that in a minute. There are several names given to surgical smoke: cautery smoke, plume, diathermy plume, or sometimes even the aerosols produced during surgery, and all sorts of air contaminants in the operating room. Some of the potential effects of surgical smoke have been studied on operating room nurses. And the most common symptoms shown by the OR nurses or doctors that are using cautery are cough, wheeze, congestion, throat irritation, flares in asthmatic symptoms, headache, fatigue, and eye irritation. I don't know if you personally have experienced any of these conditions, but these are very common in perioperative nurses, and it's been shown that these nurses have twice the incidence of many respiratory problems as the general public. Now, I will say that in my experience, cautery is used much more extensively and aggressively in the human OR than it is in veterinary medicine, but I think we need to think about these things and so on as we use cautery in our OR cases. So some of the potential hazards of plume I'll discuss in terms of odor, fumes and vapors, particulate matter, and then I'm going to talk a little bit about laparoscopic or endoscopic plume. The first thing is odor, and this is the thing that used to bug me most after a day in the OR when I would go home smelling like cautery smoke, either burning meat or hair or something like that. Some doctors say that, you know, cautery smoke smells like barbecue and they really like that. But I think that that's quite an overstatement. It's been shown that vaporizing as small as 1 gram of tissue is equal to smoking 6 unfiltered cigarettes. And I had a little bit of trouble thinking about what 1 gram of tissue would be like, but it's actually smaller than a penny. And so not very much tissue generates quite a bit of smoke. There are more than 150 chemical compounds that have been isolated from cautery smoke, some of which are toxic or carcinogenic. And we also know that similar to cigarette smoking, the inhalation of surgical smoke has a cumulative effect in terms of the respiratory system. So it's important for us to address these things as much as we can, as early as we can. The most common fumes and vapors are acrolein, benzene, and formaldehyde. But as I said, there are about 150 other chemical compounds that are known to be isolated. These are known carcinogens, despite the fact that the others can't be healthy for us to inhale either. Another thing that we need to worry about is particulate matter. And there have been studies that have shown that particles, even though there is ventilation in the operating room, the particles are more or less uniformly distributed throughout the OR because of these ventilation systems, and even travel up to 40 miles an hour. There have been some studies that have shown that nurses who have their station by the OR intake outtake get quite a heavier load of cautery smoke particles than other places in the room. So you have to be careful about the positioning of the charting station when you're looking at the operating room design. When an electrosurgery unit is activated, the room particles can rise from somewhere around 60K per cubic foot to over 1 million in some procedures. And they talk about different procedures in terms of the number of particulates that they generate. And in the human OR, one of the most common heavy particle generator are the abdominoplasty procedures, where a lot of fat is cauterized. Another tissue type that's very common to generate a lot of particulate matter is liver resections. After the cautery is used, it can take up to 20 minutes after the activation for the particle count to return to baseline. And also in the human ORs, we think about air exchanges in the OR, not completely protecting personnel from surgical smoke. But people are also thinking that, well, maybe our masks and gowns and stuff will help. And they do help, but they don't completely eliminate our exposure. So why is particulate matter important? Well, it's important because the larger particles are trapped in the nasopharynx. Apologies. So we were talking about particulate matter, and the reason it's important is because of the size of the particles and where they are trapped in the respiratory tract. The larger particles are the ones generated by the ultrasonic scalpel, and those are mostly trapped in the nasopharynx. Laser particles are smaller, and they go down into the trachea and bronchus. And electrocautery particles are the smallest ones, and those are trapped in the alveoli. So studies have shown that about 77% of plume is less than 1 micron in size. They're called ultrafine particles, and those are the ones that are really the potential health risk, and they end up in the alveoli. So it's important for us to think about this and to understand that electrocautery is really the greatest risk that we have. So I mentioned mask protection. Do masks protect? Well, masks have shown to protect people up to 5 micrometers. The high filtration masks will protect to smaller sizes, but they only really protect the upper airway, our regular surgical masks do, but only if they're worn tightly against the face. A lot of people will leave them loose, and in that case, you actually lose any protection that you might have. So there have been studies that have looked at the viability of particulate matter. And although the evidence is somewhat weak, there have been studies that have shown that when a CO2 laser was used on a cow papillomavirus, a wart virus, they were able to extract intact viral DNA in the plume. And then they injected the viral DNA from the plume back into the cow and grew the same viral lesion. So we know that there is the possibility of transmitting viable viral organisms into in the cautery plume. There's some other cases that have been reported, more or less anecdotal observations, where a 44-year-old laser doctor was biopsied who had developed a laryngeal papillomatosis, and they found the same DNA type as in the condyloma from patients. They have been able to isolate HIV-1 from aerosols during orthopedic procedures where routers and saws are used. And then finally, they've been able to show tonsillar and tongue squamous cell cancers with the same HPV from laser smoke patients. So it's fairly evident that it is possible to transmit the virus in laser plume. It's okay. Another thing that we have to worry about is endoscopic plume. Now, endoscopic plume can be generated either during laparoscopy or during an endoscopic procedure where cautery is used in the GI tract. The reason that the endoscopic plume is significant is that there is a closed cavity, and they have been able to show that there may be a patient risk for endoscopic plume in that there were increased levels of carboxy hemoglobin in patients who underwent laparoscopic laser procedures. And basically what happens is that as smoke builds up inside the abdomen, the smoke is absorbed by the red blood cells, and you get the increase in carboxy hemoglobin and methemoglobin. The problem is maybe more serious because pulse oximeter readings may be falsely elevated, and this could result in an unrecognized patient hypoxia. They've also shown that carbon monoxide levels may be increased in the peritoneal cavity and to even exceed recommended exposure limits. And this exposes the patient during the procedure and then the perioperative team when the insufflated gas is released into the OR, raising those carbon monoxide levels to higher than recommended exposure limits. I think one of the most significant things about endoscopic plume in my experience is that the endoscopic plume disturbs the visual field, and it makes it difficult to visualize internal structures. The plume can also contribute to port site metastasis. In the literature, it's called the so-called chimney effect. And this is a CT scan on the left showing the effect of port site metastasis where the endoscopic plume has traveled up the port site. So with all these factors considered, I think it's pretty obvious to all of us that surgical smoke is potentially hazardous to health, both to our health and to our patients' health. So with that limited background, I'd like to just go into the article and talk about some of the things that the authors mention as far as surgical smoke, comparing the laparoscopic and the open procedures and talking about it. During smoke evacuation practices, we have the possibility for wall suction, for an inline filter, and for smoke evacuators. And so most of us will use the wall suction with an inline filter. The problem with having the suction tip right near our procedure is that in the wall suction, it will corrode the pipes, and also that the flow may not be high enough to capture the surgical smoke. So wall suction generates about 2 cubic foot per minute, and a smoke evacuator between 30 and 50. So it is evident that smoke evacuators are more powerful than the wall suction in terms of eliminating the smoke. We don't really think about corroded pipes being a problem, but Dr. Ball gave a situation where a baby was attempting to be intubated, and they were trying to suction the oropharynx, and the wall suction failed, and the baby coded. They were able to get it back, but by bringing in another aspiration unit, but it was a a horrible few minutes, and it was caused by corroded pipes from using the wall suction. So another thing that can be done is to install an inline filter. This is used for small amounts of plume, and these are positioned between the canister and the wall suction device. So you can see the suction device here between the canister and the wall device. Then finally, you can use a smoke evacuator. Smoke evacuators both collect and filter the smoke that is generated. And so these are more powerful and more efficacious than the inline filters or the plain wall suction. There's two different types. One is called a unilateral pull. And this one on the left here is the one that's generated, is a smoke evacuator that's used. This is showing a laser fiber being used. And it evacuates the smoke from the surgical field. But you have to keep the smoke tube less than 2 inches from the generation site in order for it to be effective. And then the newer smoke evacuators have a vortex, and they're at the tip of the cautery device, and then the tube connects to that. And that's real helpful whenever there is a limited assistance available. So I think that I would advocate for these types of devices whenever possible. So let's talk about filtration for a minute. The filtration generally involves a pre-filter that captures large particles and some fluids, and then the ultra high filtration particles captures the smaller particles. And then there is a charcoal that will absorb odor. There is a coconut mesh fiber that is the product that captures the small particles. So in terms of laparoscopy, we have kind of a problem with smoke management, in that the smoke is being generated in a closed cavity. We would like to see very well, and many of us have used the approach of just opening a port on a trocar in order to evacuate the smoke, letting the CO2 fill and then letting it flow out into the room. But the newer approaches now for laparoscopic smoke management will actually filter the incoming CO2 and filter the evacuated smoke down to a level of 0.1 micron or less. And so it's a continuous flow thing that keeps the field clear, keeps the smoke evacuated, and keeps the abdomen insufflated. So now we'll go into the article review, and hopefully we'll generate some questions here at the end. So our article was published in Surgical Endoscopy recently, and the article is entitled "The Risk of COVID-19 Transmission by Laparoscopic Smoke May Be Lower Than for Laparotomy," and it's a narrative review. So the reason that this article was published is because a lot of the societies had started to advocate open surgery to minimize the risk of COVID transmission in smoke or aerosol. And so these authors took the approach of determining whether or not that was really true. And so they did an extensive literature search and actually in-depth reviewed about 50 articles. And the two questions that they wanted to answer were there any differences in smoke or aerosol between open and laparoscopic procedures? And did surgical smoke contain the virus? Was there any evidence to suggest that it did? Now, there is some evidence that COVID-19 can be transmitted in GI tract contents. And so the authors were interested to know whether there was any in the smoke. And then they answered the questions in terms of, is there any difference in the surgical smoke created between laparoscopy and laparotomy? And their conclusions were that since surgical smoke was the result of tissue vaporization, there should be no difference in composition between open and laparoscopic procedures. And everything that they reviewed suggested that, yes, indeed, that was the case. That particle size really varies with the tissue type and the type of device used, and also the procedure. And so it's really more a case of the tissue type and stuff, as opposed to whether it's an open or laparoscopic procedure. So a laparoscopic procedure is performed in a closed compartment, and then the cautery plume or cautery smoke is let out anytime there is a gas that escapes the abdomen without being filtered. And so what they found is that the dispersion of particles was greater in open procedures because the cavity is open, but the cumulative particle count was higher in laparoscopy. I'm not certain why that is. I sort of have a question about if that's really true, but that was the author's conclusion. And they cited the need to use smoke evacuators and filters for both procedures. So the second question that they tried to answer was, does surgical smoke or aerosols contain and diffuse viruses such as the SARS-CoV-2? And their conclusion was, to the best of our knowledge, SARS-CoV-2 has never been found in surgical smoke. And moreover, even if it could be found in blood, lungs, or peritoneal fluid of patients who are COVID positive, there's no compelling data to support that the disease can be transmitted through the plume or aerosolized gas, and that even if they were, if the virus could replicate, and no evidence that there's any difference in plume or aerosol between laparotomy and laparoscopy. So this is a fairly significant conclusion, considering the recommendations of the surgical community, which had been towards open procedures. Will perfect containment and proper evacuation systems make laparoscopy safer than laparotomy? Well, basically the conclusion of the authors was that opening the trocar cannulas for smoke evacuation to improve visibility should always be avoided. And that to attenuate particle load in laparoscopic surgery, they recommended a continuous flow of fresh CO2 during the activation of electrosurgery devices, rather than a periodic release of smoke only when the view is compromised. And these authors suggested that laparoscopy might be safer than laparotomy because surgery performed in a closed cavity separating from the open operating room space by the abdominal wall, that the plumes are contained in the abdominal cavity until they're properly evacuated. And this is not possible in open surgery. It's released into the general air. So the author's conclusion from this paper were that laparoscopy would be advocated for those patients in whom it would have been safe to perform in the first place. The limitations of this study was that there was limited data. Their level of evidence was low. There were very few studies that they reviewed that were randomized control studies, and no scientific studies that actually address this specific question. And then also when they did their literature review, there were a wide variety of terms for surgical smoke that they looked at, and it's possible that they could have missed some article in their review. So I thought that what we would do in the final few minutes is just review their table 1 for tips and tricks to ensure that aerosol safety during laparoscopic surgery. And this is found on the next to the last page, just before the conclusion. So their first thing to ensure aerosol safety was that hand-assisted laparoscopic surgery should be avoided. And that I think that we're talking about all things being equal. And it says that as SARS-2 was found in the stools of about 50% of COVID-19 plus patients, if the digestive tract is open or if there's perforation and spillage, it should be lavaged. Of course, that is the case. But they also mentioned that if a gastrointestinal resection is planned, that you should seal off the up and downstream segments, and maybe that a stapler would be better than a clamp. And if division with energy-driven devices was thought of, that it should be avoided, not to create a virus-laden smoke. In other words, not to use the cautery devices to make your enterotomy incisions. And I don't think many of the veterinarians actually do that, because we're more concerned about healing. And then they have several tips and tricks about management of port sites and trocars. Avoiding opening trocar stopcocks during surgery, and maybe even sealing them with a protective cap like a lure lock stopcock or something like that. 1 or 2 dedicated trocars should be connected continuously to a filter by lure locks and open to evacuate the smoke, which is then filtered before exiting into the OR or ideally into another evacuation system. And then it talks about how to insert and withdraw the instruments and trocars, making sure that there's very little leakage around the trocar site insertion, making sure that they're well planned so that they go in smoothly and so that they don't come out, making sure that you don't have any torque on the trocars so that, again, they stay in place. And then they talk about evacuation of the pneumoperitoneum, stating that several ports can be utilized for desufflation, but whenever possible, do it through the most anti-gravity port. And that port site closure should be started only after complete desufflation. Again, this is just talking about how to really make sure the abdominal cavity is empty before, so that there's no loss of gas from the inside of the abdomen to the operating room air. Making sure that you check all, air tightness of all the trocars so that all the seals work. And they say ideally disposable trocars should be preferred over reusables. Evacuation energy created smoke should be evacuated through filters continuously and not only when smoke compromises visualization. And then they make some recommendations about air seal ports and some other ports that are available. To use as low of a pneumoperitoneal pressure as possible. I think that all of the veterinarians try to practice that as possible, and not to use trendelenburg for more than 10 to 15 degrees. And then regarding energy devices, choosing bipolar energy over unipolar whenever possible, using the lowest possible energy level. And then they talk about keeping the pulses short and avoiding long use of energy on the same tissue type. That's just to limit the amount of vaporization that occurs with the application of the energy to the tissue. And then they talk about if you put in a drain, making sure that it stays sealed until the procedure is complete. And keeping the operating instruments clean, and all OR personnel wearing a tight sealing mask in the OR. So these are all clues that they had about addressing laparoscopic surgery. So applications to veterinary medicine. In my experience, there is rather limited use of smoke evacuators in open and laparoscopic surgery. But we do have an opportunity to really improve workplace safety, and I think every one of us would advocate for an improved environment for ourselves and our OR teams. When I was thinking about surgical smoke, I was thinking about the various aspects of surgical smoke as potential research projects for residents. When I reviewed the literature, there was very little written about surgical smoke in veterinary medicine. And I think that there is some data in the human about the different tissue types. But again, in veterinary medicine, very little. And any research that we might do, I think, would also contribute to our understanding of the risk of and hazards of smoke plume, even in open surgery for people. So I think that I would be thinking about different types of research projects that might be applicable for residents that could be easily studied ex vivo, and it would make a good research project for a resident and contribute to the overall safety of our workplace in veterinary medicine. You know, I think it's ironic that we advocate for smoke-free facilities everywhere, and yet the operating room is one of the most smokiest environments that you can find. And there's a lot of talk being done about how to create smoke-free facilities. The AORN has a special effort towards that. There's states that have passed laws regarding the use of the need for smoke evacuators in hospitals, and I think it reasonably will also apply to veterinary medicine. And so I think that this is something that's going to get more and more attention as we go forward, and so it's just prudent for us to pay attention to these types of things and be on the leading edge of smoke evacuation in veterinary medicine. So that's what I had thought about. My questions have to do with whether folks have had experience with smoke evacuators, and maybe to have some opportunity to weigh in on what things are working well and what things others might recommend to our colleagues. So Chris, if you want to facilitate any questions, I'll be happy to answer them, or any comments that are there in the chat room.
Yeah, perfect. Thank you so much. That was really, it was a really great presentation. I think a really great review, not just for minimally invasive, but for general surgeons, especially because this affects us so much and has the potential to truly impact our health and our patients. So that was really great. If anyone has questions, please add them to either the Q&A or to the chat box, and I will pass those on to Dr. Freeman. One thing I will kind of ask that I know we were talking about at my previous institution at CSU is it does seem that there seems to be at least a small push on the human side and somewhat on the veterinary side that there may be increased regulations towards the safety of surgical smoke. Do you think that that will become an issue for veterinary practice and veterinary surgeons as we move forward?
I suspect that it will. It seems like anything that is advocated in the human field trickles down to veterinary medicine within a short order. And but I think that regulations really should be the reason that we do this. It should be that, you know, we're being proactive about protecting our own health and welfare. So I would just advocate for doing it because it's the right thing to do.
And did you guys have any experience where you were in terms of adding smoke evacuators?
So at Purdue, one of our surgeons really felt the need for the smoke evacuators and ordered one and got it in. And when that surgeon was in the operating room, it was being used, but the person is no longer there and the smoke evacuator is not being used anymore. So I think that you know, it's difficult to change behavior, and so in order to do that, we're going to really have to create awareness and then have some champions at each institution who are going to basically lead the charge, so that you know, we can make these changes and make them be effective.
Yeah, I fully agree. I think when I was at CSU, there was, the year that I was there was a very large push towards smoke evacuators. And they had trialed several different types and then installed them just before I got there. And I think that one of the biggest benefits, or one of the biggest reasons that it was kind of onboarded or taken up so efficiently at CSU was the fact that the OR nurses were the ones that were really driving a lot of that change. Meaning that they had it completely set up, so by the time that you walked in, there wasn't a question as to whether or not you were going to use it. It was just available. And so I think that it was easily adopted just because it was emphasized and efficiently put into place. So I thought that was a really great opportunity.
Yeah, I mean, it's really, we're in the operating room for our cases, but they're in the operating room all the time. And so Dr. Ball talks about how to create change and how, you know, education is needed for the OR staff, and then the OR staff needs to basically take the charge for making these things happen. But I think as surgeons, we need to also champion it so that we're not fighting it.
Yeah, absolutely. So there aren't any current questions at this point. Did a fantastic job. If there are any questions, we can definitely answer those on the listserv as well.
Sure.
But again, if there are no other questions, do you have any final comments, Dr. Freeman?
No final comments, just want to encourage everybody to think about these things, think about some research projects that might be fruitful areas to explore, and then feel free to email me or post a question to the listserv if there are any questions.
Awesome. Thank you so much. And thank you everyone for attending. And again, we're excited to bring these things to VES. If you like them, I will send out a quick survey for everyone. But if you like these, please let us know. And thank you again, Dr. Freeman, for being our champion for the Journal Club.
Yeah, my pleasure.
All right, we'll see everyone later.
Okay, bye-bye.